All right, so we're going to do chapter 3 here, which is going to be lifting and moving patients. So we'll talk about protecting yourself with proper body mechanics. We'll talk about moving the patient and protecting them while we're doing it with emergency moves and urgent moves and non-urgent moves. Start off by talking about proper body mechanics. So what are body mechanics? Body mechanics is the proper use of your body to prevent injury and to facilitate lifting and moving of patients. Simple as that. It's how you use your body in a proper way to keep from getting hurt and still get the job done. So before you lift any patient, you want to consider several factors, including the object itself, like how big is it, how heavy is it awkward to lift, things like that. Do you need additional help to lift it? Most patients, you are going to need a second person to lift. You have to know and be aware of your limitations. I've seen people get hurt being the tough guy, like, oh, I can get it, when they really just could have said, I need some help lifting this, and they would have been okay. So you got to know your limitations. And you have to communicate well. Before you lift a patient, you should have a plan, and it should be communicated clearly to the entire team. So there's several rules that we want to know for lifting. First, we want to position our feet properly, and it's going to be about shoulder width apart, directly underneath you. You want to bend your knees and use your legs. You have a lot of power in your legs and in the butt, so you can use that for most of your force there. You don't want to turn or twist. You're going to be putting a lot of strain on your back, and you don't want to compensate when lifting with one hand. You just want to lift easily there. So when you're lifting, you want to keep the weight in as close as possible to your body. The further you reach out, the weaker and less stable you become. And it makes it easy for you to get hurt the further you reach away from your body. Use a stair chair when carrying a patient on stairs whenever possible. If you can put a patient in a stair chair, use it, and we'll get to what a stair chair is and how to use it here shortly. There's a stair chair right there being used. They're lifting this patient in the chair down the stairs. It's a minimum of 2 people to operate, and it's preferably operated with 3 people, as we've seen here. All right, we'll talk about the power lift and the power grip. All right, so our guy here on the left, he's got his feet spread apart there. He's got his power grip, which is gripping with your hands there, so your palms are facing away from you. He's keeping his back straight, and he's bending his knees. On the right, we see a close-up of his grip. That would be the power grip, and how he's employing that with the lift on the left. All right, when you're reaching out, you want to keep your back in a locked-in position. You don't want to arch it or bend too much with your back. Avoid twisting while reaching. Again, it destabilizes your platform, your body, and it makes us vulnerable to injuries, muscle-related injuries mostly. Avoid reaching more than 20 inches in front of your body. You want to keep everything about 6 to 10 inches in front of your body there. So avoid that reaching more than 20 inches. You lose a lot of strength when you reach out. And avoid reaching for prolonged period of times. When pushing or pulling, it's best to push rather than pull whenever possible. You can use the strength from like your legs and your arms together to push, and it's going to be easier on your body. When you're pulling, you're going to involve more of your back, and that's where a lot of injuries can happen. Keep that back locked in, keep it straight, and you want to pull through the center of your body. You don't want to pull to the side so you end up twisting. You want to pull through the center of your body and keep the weight close to your body again. If you're pushing or pulling and it's an object that is below your waist, then get on your knees and push or pull from a kneeling position there. It'll help your back. Avoid doing the pushing or pulling overhead. Again, that is going to be you stretching your arms out, and we're not in a position of power there. So you open yourself up to injury doing that. Keep your elbows bent and close to the sides. There, that'll help protect you as well. All right, and before we move on to the moves for the patient, emergency, urgent, non-urgent, just to let you know, we will be practicing lifting and moving in the classroom. All right, we're going to talk about emergency moves. Emergency moves, we're moving the patient very quickly because the scene is hazardous. There's a life-threatening incident happening where if we don't move the patient, then the worst of patient outcomes could happen. Maybe they possibly die there. So to care for this patient, we require them to be moved or repositioned, right? Somebody's in a burning car, we have to pull them out, something like that, right? Or you have to reach another patient. We have to reach another patient who has a life threat going on, so we don't have the time to just nice and easily move somebody out of the way. Here's an example of a way to move somebody here. He's doing the clothes drag. He's just grabbing the clothes, kind of balling it up behind the shoulders and with the neck there, and he's going to drag him backwards. Here we have the incline drag, pulling him down some stairs. As you can see, what he's doing, he's got his arms underneath the patient's armpits, and he's grasping his forearms, or right about at his wrists there, and he's pulling him down the stairs. Always go head first. Please don't pull a patient down the stairs, holding them by their feet. You're just going to bounce their head off of the stairs. You probably don't want to do that. This is called a firefighter's drag. They use this obviously, in smoke-filled environments and things like that. What the EMT is doing is basically straddling them. They've tied their wrists together like that. As basically a connection point. They put their arms over his head, and he starts to crawl forward there, and that will help drag the patient along. As you might guess, this is probably not used very often in EMS, but it should be in your toolbox nonetheless. Here we have a blanket drag. They're moving somebody, so this picture is kind of misleading because you're not going to be able to pull somebody with one hand. Right? That person in the blanket is heavy, and you're not going to be able to pull somebody with one hand like that. So this is a bit misleading. You're probably going to have to turn around, face the patient, either kneeling or sitting, and then pull them to you, reposition yourself a little further back, pull the patient to you again. Kind of like a rowing motion. And here we have just one rescue or assist in moving the patient. This is like your common way to move somebody like that. I'm sure we've all seen that before. Here's a 2 rescuer assist there. So an arm around each of the rescuer's shoulders to bear the weight of that patient. All right. Urgent moves are when we need to move quickly. However, we do have a little bit of time in order to move them. We may be able to provide a little bit of care. So it's we use an urgent move when the required treatment can be performed only if the patient is moved. Factors at the scene could cause the patient to decline. Was it a smoke-filled area? Was there a hazmat spill in the area? Is there chemicals in the air? Is it cold outside? Like really cold? Some of those could be factors there. All right, so one of the examples of an urgent move is moving a patient from a car onto a long spine board. Now, all this takes a little bit of time to do this. This takes a few minutes to do this, and so, for example, we wouldn't do this if the car was on fire. We would use an emergency move to get them out of there quickly, right? So this, putting a patient on a backboard, is an urgent move. So we're going to do this in case there's any threats to life and or suspicion of spine injury because of injuries they may have. If they're supine, if they're on the ground, we'll log roll them onto one side, place the backboard behind them, and then log roll them back onto the backboard. After we get them on the backboard, we'll lift them up onto the stretcher, secure them to the stretcher, and then load them into the ambulance. So there's rapid extrication as well, and it's used when taking time to immobilize the patient with a short backboard or a vest before moving the patient may cause a deadly delay. So that's moving them onto like a spine board without first immobilizing them onto a short backboard or using a vest to do so. And frankly, both of those, the short backboard and the vest, are not as in use as much today in the field. It's rare that a provider would use like the vest nowadays, especially. So what you do is, instead of putting the vest or the spine board on the short backboard to immobilize the spine, you do it manually, and then you move them onto the backboard, and we'll learn how to do rapid extrication. Non-urgent moves, these are your normal stuff. The patient's stable, grandma says she's not feeling well, so you get her to walk over to the cot, when you need her to, and then you move her to the ambulance. This is normal situation stuff. No immediate life threats. The patient can be assessed and treated and moved in normal ways. All right, so let's talk about some things we move patients on. Stretcher or the cot. We have a few different types of stretchers, and we have the cot here. Basically, the name's interchangeable. They're designed to carry the patient safely to the ambulance and or the hospital. All right, so we have the wheeled stretchers. Some of them are power stretchers. So if you go to basically any rescue squad around here, I think everybody has the power stretchers where you can press a button and the stretcher lifts all the way up into its proper position, or it can go all the way down or stop anywhere in between. We have the manual stretcher here at school. These are still out there all over the place. The manual stretchers, where you actually have to lift the stretcher up off of the ground and do the work to get it in the ambulance yourself. There's bariatric stretchers. These are for your severely obese and overweight patients. They're designed to hold much more weight, and they are much wider as well. As it said here, some can carry patients weighing up to 800 pounds or more. So these are big, sturdy devices. All right, here's a type of, this is a power stretcher. Actually, you can see the buttons that it's got on here to lift it, get it up into that position, or to lower it into another position. there when you're loading your patient onto the stretcher, or for when you're putting it in the ambulance or moving it to the ambulance. Here is a bariatric stretcher setup. As you can see, it's totally different there. So we've got a much larger stretcher. It's much wider. It's much more heavy duty. It's reinforced. And because of the patient's weight, you have big handles at the front and the back. And instead of just lifting the stretcher into the back of the ambulance and pulling up the wheels, it's got basically these tracks that it will use to get all the way up into the ambulance. All right, so stair chairs. We saw a picture of a stair chair earlier, and obviously it's used to move patients up and down stairs. This is really useful in homes that may have narrow hallways or narrow stairwells where you can't get the stretcher up or down, or I mean, obviously you don't want to take a stretcher up a full flight of stairs anyways and try to get the patient down on it. So that would just be not safe. The stretchers, cots, they're heavy. Whether it's you lift it manually or it's a power cot, they're heavy. So we use stair chairs a lot. These are safe, they're convenient, and they're quick to use. There's a spine board or backboard. There's a short board, and it's primarily for moving patients from inside of a car when neck and spinal injury is suspected onto a long backboard on the cot. Now there's the long board, which is what we normally put somebody on. So you would use the vest or the short backboard to move them to the long board and put them on that. Again, a lot of the short backboard and the vest usages is kind of going the way of the dodo. It's not in practice in a lot of places. Here's a picture of a stair chair. What's great about these is it's hard to see back here, but there are tank treads on the back, and so when it goes down a stair, you just lean the patient backwards. Those tank treads are self-braking, and so it just glides gently down the stairs, and they're real nice to use. We'll use ours. This is a short backboard. They're still carried on ambulances, but the times that you'll use them will be probably very few. Here's some long backboards, some longboards or backboards as they're called. They used to be made out of wood. These are made out of hard plastic now, so that they can be easily cleaned and blood and other bodily fluids won't soak into them like they would in a wooden backboard. All right, so there's other types of stretchers. There's portable stretchers. There are scoop stretchers, which are used for hip pelvic injuries. There's a basket stretcher, which is a hard plastic type of stretcher. Oftentimes has metal rails, and you belt a person into it. A lot of times these are used for, if somebody crashes their car, off an embankment into the woods, they'll put them in this, and then they'll carry them in this stretcher up to the road, and then they'll transfer them to something else. There's a flexible or Reeves stretcher. A lot of times you'll use this in a patient's house that has a narrow hallway or narrow stairwell where you can't get the stretcher up there, and you may use that to carry them down to the stretcher. Vacuum mattresses, those are still out there once in a while. You may hear of one of those. This is an immobilization device. There, it's called the Kendrick's extrication device. It's a vest. You put this on the patient while they're in a car and use it to move them out of the car and then onto a backboard where you would take this thing off. This is very rarely used in my experience, and from most of the experience that I can tell and speaking with people. You just don't see this much nowadays. It takes a long time to put on and the time to get off, and so you're spending probably more than the time that you wanted to spend on scene. This is a scoop or orthopedic stretcher. it separates in the middle, and so you can put it on either side of the patient and literally scoop them up without having to move them around too much. This is particularly good for people who have hip or pelvic injuries. This is a basket stretcher or a Stokes stretcher. There again, this would be like if you had to walk down a mountain with a patient, or they crashed their car down an embankment into the woods, and you had to get them from the car back up to the road. You put them in this and carry them up to the road in there. Here's a flexible stretcher. There, pretty old one. You don't see those. And here's a vacuum mattress. You put them on this, and you kind of the air fills in the spots where they're supposed to go. So see, he's going to blow up the air there, and it fills in the spots where it'll hold them into place a bit there. All right, so moving patients onto carrying devices. So with somebody that has head, neck, or spinal injuries, we want to immobilize the head, neck, and spine before we move them. That's ideal. We'll perform manual stabilization of the C-spine. That's literally holding their head from the back. You're behind them, holding their head, not allowing them to move it. You want to keep that head in a neutral, nice neutral position, looking straight forward there. We're going to put a collar on them. It's a rigid cervical collar or C collar there that we'll put on them that will prevent them from moving their head around. And then you're going to maintain, despite them having the collar on, you're going to maintain manual stabilization of C-spine, of the spine, until they're fully immobilized on the backboard. And we'll show you that, what that looks like. Moving a patient with no suspected spinal injury, use the extremity lift to lift them. You can use it to carry them to a stretcher, or stair chair, things like that if they're laying on the ground. They can be used to lift them from a ground or sitting position in a chair as well. There. Here's a view of the extremity lift. Now note again, our guy, this is the same person he was dragging down the stairs, right? He's got his arms underneath the patient's arms, and he's grasping their wrists. That actually helps a lot, so you can do that. All right, so with no suspected spinal injury, if they're laying on the ground, we can do a direct ground lift. It's literally putting your arms underneath them and lifting them from the ground to the stretcher. There we go. So you got one EMT that's going to get basically the upper body, and the other EMT is going to be responsible for the lower body. But basically, both of your hands are going to be down right behind the patient's hips there. So they move the patient up up on top of their knees, and then for the next part, they slide them over onto the bed. Nice and easy. All right, with no suspected spinal injury, we can also use the draw sheet method, the direct carry method. Here's the draw sheet method. We're moving them from a bed to the stretcher. Okay, so this could be in a nursing home or a hospital facility, long-term care facility, things like that. They're going to loosen the sheets from around the bed and kind of roll them up. They're going to take this part of the sheet on the close side of them, and they're going to roll it up right next to the edge of the patient there to take up any slack, and they're going to pull her right over onto there. So this is mainly how we transfer a patient from the cot to the hospital bed when we get to the hospital. All right, here's a position that we can put somebody in the hospital that's helpful for us. It's called the recovery position. Normally we'll put somebody on their left side in the recovery position. So this can help. Now, it can help with airway problems. It can help if the patient is unconscious. a bit there. Can help if they're vomiting. Can help use gravity there to our use gravity to aid us in doing airway maneuvers there, which we'll get into a bit there. That's the recovery position. We need to know what that's called. More patient positioning for shock. Any patient that is believed to be in shock, and we'll get to what that means. We want to lay them in the supine position, which is laying on their back in the supine position. We don't want to lower their head. We don't want to have them on an angle. We want to have them flat in the supine position. We don't want to raise their legs, nice and flat. When we get to the hospital with the patient, we're going to transfer them from our cot to the hospital bed. A lot of times we just use that draw sheet method that we saw before there. So it's always nice to get some other people on the far side of the bed. So if you got doctors or nurses, whoever they may be. So we got these nurses right here. They're going to grab the near side of the sheet. The EMTs are going to grab the side closest to them and kind of lift. And these guys are going to pull. The guys on the right, they're going to pull. And that'll get the patient right over into the bed. And then they talk about how awesome they were and how it worked just fine. Nah, I'm just kidding. They do the handoff report here. So the EMTs would be talking to the nurses about what exactly is going on with our patient. All right. Any questions, just let me know. Make sure you have read the chapter and taken notes. And we will see you next time.